My name is Dr. Sarah Chen, and I've been working as an anesthesiologist at St. Mary's Medical Center in Portland, Oregon for the past 18 years. In my profession, we're trained to control consciousness itself. We guide patients into that liminal space between awareness and oblivion, then safely bring them back. It's a responsibility that requires absolute precision, unwavering focus, and complete trust in our equipment and protocols. But what I'm about to tell you is about the one case that made me question everything I thought I knew about consciousness, awareness, and the thin line that separates the two. St. Mary's is a major trauma center serving the Pacific Northwest. Our operating theaters handle everything from routine procedures to the most complex emergency surgeries. The anesthesia department works around the clock, managing consciousness for hundreds of patients each week. During my career, I've administered anesthesia for over 10,000 procedures. Brain surgeries, heart transplants, emergency trauma cases where seconds determine whether someone lives or dies. I've seen patients slip away under anesthesia and fought to bring them back. I've witnessed the moment when consciousness returns and watched families reunite with loved ones they thought they might lose forever. This story begins on a cold Thursday morning in November 3 months ago. I was scheduled for what appeared to be a routine neurosurgical procedure. The patient was a 42-year-old construction worker who had suffered a severe head injury in a workplace accident. A piece of heavy machinery had struck him directly in the forehead, causing significant trauma to his frontal lobe. The neurosurgical team needed to remove bone fragments and address bleeding in his brain, while he remained completely unconscious and immobile. What made this case unusual wasn't the surgery itself, but the patient's condition when he arrived. According to the medical records, he had been unresponsive for nearly 2 weeks following his accident. The trauma team at the referring hospital had managed his immediate injuries, but he had never regained consciousness. His brain scans showed extensive damage, and the consulting neurologist had classified him as being in what we call a minimally conscious state. His eyes would occasionally open, he would sometimes appear to track movement, but there was no evidence of meaningful awareness or ability to communicate. When I first met with his wife in the preoperative area, she was exhausted from 2 weeks of hoping and waiting. She explained that her husband had always been incredibly strong-willed and determined. Before his accident, he had worked as a foreman, managing construction crews and solving complex problems under pressure. She insisted that sometimes when she talked to him about familiar topics like their children or his work projects, she could see something in his eyes that suggested he was still there, still listening. I had heard similar stories from countless families over the years. The desperate hope that their loved one was more aware than medical tests could detect. As an anesthesiologist, I understood the delicate nature of consciousness better than most. But I also knew the harsh realities of severe brain trauma. The scans were clear. The damage was extensive. The likelihood of meaningful recovery was virtually non-existent. The surgery was scheduled to last approximately 4 hours. My job was to maintain him in a controlled unconscious state while the neurosurgical team worked to remove damaged tissue and stabilize his condition. I had reviewed his medical history thoroughly, calculated the appropriate medication dosages, and prepared all the standard monitoring equipment we use to track vital signs and brain activity during surgery. What I discovered during the preoperative setup would fundamentally change my understanding of consciousness and leave me questioning assumptions I had held for my entire career. As I was connecting the standard monitoring equipment, I noticed something unusual in his baseline readings. The machines that measure brainwave activity were showing patterns that didn't match his supposed level of consciousness. Instead of the minimal, irregular activity I expected from someone in his condition, the monitors were displaying organized, rhythmic patterns that suggested much higher levels of brain function. I double-checked the equipment, thinking there might be a technical malfunction. I disconnected and reconnected the monitoring leads, calibrated the machines, and ran diagnostic tests. Everything appeared to be functioning normally. The brainwave patterns remained consistent, showing activity that was far more organized and purposeful than anything I had seen in a minimally conscious patient. Even more puzzling was how these patterns changed when I spoke directly to him during the preparation process. As anesthesiologists, we're trained to explain procedures to patients even when they appear unconscious, both for legal documentation and because there's always a possibility that some level of hearing persists even in compromised states. But when I began explaining what we were about to do, the brainwave monitors showed distinct changes in activity. The patterns became more pronounced, more organized, almost as if he was actively listening and processing the information. I called over Dr. Martinez, the neurosurgeon who would be performing the procedure. He examined the monitor readings with growing confusion. According to every assessment tool we had available, this patient should have been showing minimal brain activity. Instead, the machines were displaying patterns that suggested conscious thought, active processing, and what appeared to be intentional responses to external stimuli. We spent nearly 30 minutes running additional tests and trying to understand what we were seeing. The brain imaging from 2 weeks earlier clearly showed extensive damage to areas responsible for consciousness and awareness. But the real-time monitoring during our preparation suggested that somehow, despite this damage, much higher levels of brain function were present than anyone had realized. The most disturbing moment came when I was adjusting the final monitoring equipment before beginning the anesthesia process. I had positioned myself directly beside his bed, speaking in my normal procedural voice about the medications I was about to administer. Suddenly, the brainwave patterns on the monitor changed dramatically. The activity spiked in a way that suggested not just awareness, but what appeared to be distress or anxiety. I looked down at his face, and for just a moment I could have sworn I saw his eyes move. Not the random reflexive movements that are common in minimally conscious patients, but deliberate, purposeful tracking. His gaze seemed to find mine and hold it with an intensity that made my breath catch in my throat. The implications of what I was witnessing were staggering and terrifying. If this patient was aware, truly conscious, and listening to everything we were saying about his condition, about our plans, about his prognosis, then he had been trapped inside an unresponsive body for 2 weeks. He had been present for every discussion about his hopeless condition, every conversation about quality of life decisions, every moment when medical staff spoke about him as if he weren't there. I had to make a decision that would haunt me for months afterward. Do I proceed with the surgery as planned, or do I stop everything and investigate what the monitors were telling us? The neurosurgical team was ready, the operating room was prepared, and this patient needed the procedure to prevent potentially fatal complications from his brain injury. But the thought of putting someone under general anesthesia when they might be fully aware and unable to communicate was absolutely terrifying. Dr. Martinez and I decided to proceed, but with modifications to our standard protocol. I would use lighter levels of the medications than usual, maintaining just enough unconsciousness for the surgery while preserving as much brain function as possible. We would monitor his responses continuously throughout the procedure, watching for any signs that our assumptions about his condition were wrong. As I began administering the first round of medications, I watched the brainwave monitors with an intensity I had never experienced before. The organized patterns we had observed during preparation began to shift and change as the chemicals took effect. But instead of the gradual, predictable decline in activity that I expected, something else happened. The monitors showed what appeared to be active resistance to the medication. The brainwaves spiked and fluctuated in patterns that suggested he was fighting against the loss of consciousness. It was as if his mind was struggling to maintain awareness, even as the pharmaceutical agents worked to suppress it. I had never seen anything like it in 18 years of practice. Even more disturbing was what happened when I increased the medication dosage to achieve the level of unconsciousness required for the surgery. The brain activity didn't simply decrease gradually as it should have. Instead, it seemed to reorganize itself, creating new pathways and connections that allowed some level of awareness to persist even under deep anesthesia. Throughout the 4-hour procedure, the monitoring equipment continued to show these unusual patterns. During the most intensive parts of the surgery, when the neurosurgeon was working directly on damaged brain tissue, the monitors would display sudden spikes in activity. It was as if the patient was somehow aware of what was happening to him, even while under what should have been complete unconsciousness. The surgical team noticed these anomalies as well. Dr. Martinez commented that he had never seen brain tissue respond the way this patient's did during the procedure. Areas that appeared severely damaged on the imaging studies showed signs of electrical activity when touched or manipulated. Regions that should have been completely non-functional seemed to be communicating with other parts of the brain through pathways that weren't visible on any of our scans. About 2 hours into the surgery, something happened that made everyone in the operating room stop what they were doing. The patient's heart rate suddenly increased dramatically, even though his blood pressure remained stable and all other vital signs were normal. This type of cardiovascular response typically indicates that a patient is experiencing pain or distress despite being under anesthesia. I immediately adjusted his medication levels, adding additional agents to ensure complete unconsciousness. But the heart rate elevation persisted. More concerning was what the brainwave monitors showed during this episode. The patterns became incredibly organized and intense, almost like the electrical signature of someone who was not only conscious but experiencing extreme emotional distress. Dr. Martinez had been removing bone fragments from near the patient's frontal lobe when this cardiovascular event occurred. He paused his work and looked at the monitors with obvious concern. In 25 years of neurosurgery, he had never seen a patient's brain respond this way to surgical manipulation while under general anesthesia. We made the decision to lighten the anesthesia slightly, hoping to understand what was causing these unusual responses. As the medication levels decreased just marginally, the brainwave patterns became even more pronounced and organized. The monitors were showing activity levels that were completely inconsistent with his supposed neurological condition. Then, approximately 3 hours into the procedure, the most shocking thing happened. While Dr. Martinez was working to remove the final pieces of damaged tissue, the patient's eyes opened. Not the reflexive, unfocused eye movements we sometimes see under anesthesia, but deliberate, purposeful opening that seemed to indicate conscious awareness. I immediately checked all the monitoring equipment, convinced that the anesthesia had somehow failed, but the medication levels in his bloodstream were exactly where they should be for complete unconsciousness. According to every measure we had available, this patient should have been completely unaware of his surroundings. Yet his eyes were open, moving, and seemed to be tracking the surgical lights above him. Dr. Martinez stopped the procedure entirely. We couldn't continue operating on someone who appeared to be conscious. Regardless of what our equipment indicated about his anesthetic state, but we also couldn't wake him up completely in the middle of brain surgery without potentially causing catastrophic complications. For several minutes, we found ourselves in an impossible situation. The patient's eyes remained open and alert-looking, but he showed no other signs of consciousness. He didn't respond to verbal commands, didn't show any facial expressions or attempt to communicate. It was as if only his visual awareness had somehow broken through the chemical barriers we had created. The brainwave monitors during this period showed patterns unlike anything in the medical literature. The electrical activity was intense, organized, and appeared to be concentrated in areas of his brain that should have been severely damaged according to his imaging studies. It was as if his consciousness had found alternative pathways to maintain some level of awareness, despite both the original injury and our pharmaceutical interventions. I made the decision to deepen his anesthesia significantly, using combinations of medications that would ensure complete unconsciousness regardless of his brain's apparent resistance to our standard protocols. Slowly, his eyes closed and the unusual brainwave patterns began to normalize. Dr. Martinez was able to complete the surgery without further complications. But the experience left everyone in that operating room deeply shaken and questioning fundamental assumptions about consciousness, brain injury, and the nature of awareness itself. The surgery ended successfully from a technical standpoint. The patient recovered from the anesthesia normally and returned to his previous minimally conscious state. But I was left with questions that have haunted me every single day since. 3 months later, I still hear those machines in my sleep. The rhythmic beeping, the electronic signatures of a mind that defied everything we thought we knew about consciousness and awareness. I've spent countless hours researching similar cases, consulting with colleagues across the country, trying to find some explanation for what we witnessed that day. The medical literature offers no answers. The brain imaging studies remain unchanged, showing the same extensive damage that should have precluded any meaningful awareness. Yet I know what I saw on those monitors. I know what we all experienced in that operating room. The patient was eventually transferred to a long-term care facility. His wife continues to visit him daily, talking to him about their children, their memories, their hopes. She still insists that sometimes she sees recognition in his eyes, that he responds to familiar voices with subtle changes in expression that the medical staff dismisses as coincidental. But I don't dismiss them anymore. After what I witnessed during that procedure, I've fundamentally changed how I approach every case involving questions of consciousness and awareness. I listen more carefully to families who insist their loved ones are more present than our tests can measure. I pay closer attention to the subtle signs that our sophisticated equipment might be missing. This case has taught me that consciousness remains one of the greatest mysteries in medicine. We can map the brain, measure electrical activity, and track chemical changes. But we still don't fully understand what it means to be truly aware. The boundary between conscious and unconscious may be far more complex and permeable than we've ever imagined. Every time I enter an operating room now, I wonder how many patients might be experiencing more awareness than we realize. How many times have we spoken about someone as if they weren't there when perhaps they were listening to every word? The responsibility of that possibility weighs heavily on every procedure I perform. The machines may have stopped beeping that day, but in my mind, they never really went silent.